Here we are, Real Recovery Talk. I am your host, Tom Conrad. In today's episode, we've got Benjamin B.
What's happening, everyone?
And we got Dr. T.
Hello, everyone.
First things first, thank you for tuning in on the podcast app, whichever one that you choose to use. And thank you for watching on YouTube. In the end, if you have any comments, questions, or concerns, you could always reach us. info@realrecoverytalk.com. Again, it's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message. Right, Ben?
Yes, sirree.
Right, T?
Yes.
How's it going, guys?
Good.
We haven't sat in these seats in like a week and a half.
It has been a week.
Mm-hmm.
Oh, yeah. How's everybody's lives?
Going. It's January. This month feels like it's been forever.
Well, January's almost over.
Thankfully.
It's Hattie's birthday tomorrow.
Oh,
Is it?
Hattie.
Yeah.
Oh.
We're going
What are you doing?
Going to Disney.
Oh, all right.
Yeah. You didn't get the memo?
No. Tom never lets me know when he's leaving town.
Yeah. I don't really tell anybody. I'm like a ninja.
I feel like I should know.
Yeah, you should. You're right.
He's your work husband. It's important.
No, he's the wife.
Oh, he's the wife. Okay.
Yeah.
No, you had it right the first time.
Anyways, I was watching television 3 nights ago and came across a clip that Pierce Morgan had on his channel, and it had on Zuby. And I don't know much about Zuby. I do know, and you'll like this, Ben. Zuby was in fact on Mind Pump's podcast.
Oh, really?
Yep.
No kidding. Is that how you found him?
Yeah. That's how I find a lot of people.
That's how you find everybody.
Yeah. So, but anyway, Zuby is good guy from what I understand. I believe he makes music, and he is a pretty big voice now in terms of mental health. And what the clip really was portraying was, where is our mental health crisis stemming from? And I thought this would be a good discussion, at least from our perspectives, what we think and what we see, and how mental health really translates into addiction, and how we essentially treat mental health here, and what are the outcomes that we kind of see with it, Because mental health, I think, at least from my perspective, is, we get these phone calls, Ben and I do, all the time from parents. And they're like, well, and one of the questions that at least I ask is, does your son or daughter or spouse have any diagnosed mental health issues? And a lot of times, if they're not diagnosed, the way the conversation will go is, no, they're not diagnosed, but. And then after the but, there's always, the typical anger outbursts and, very high highs, very low lows. They don't come out of the room. I think they're depressed. I think they may have bipolar. I think that they may have some sort of schizophrenia, so on and so forth. And so the loved ones are left really just kind of extremely unsure. And then I go on to tell them, well, it's really hard. And Tambini, this is where you can chime in here. It's really hard to diagnose somebody with any sort of mental health issues when they're using, because you don't know if they're using is causing the mental health issues, or if their mental health is causing them to use. So anyways, we'll open it up from there. Either or.
Do you want to start? Or, this can go in different trajectories. We can bounce back and forth.
I would say this comes back to, and we've talked about it in the past, like Tom was saying, we get these phone calls and we do these pre-admission screens. And one of the questions on there is, do you have any past or present diagnosis? And I always get the same few: ADHD, generalized anxiety disorder, major depressive disorder. What are some of the other ones? Bipolar.
Yeah.
And those are the 4 most common that I believe I see. And realistically speaking, and I'm not the doctor here, but probably 75% of the time what they're self-reporting isn't exactly accurate. And that comes down to kind of like you, I think you were just alluding to, Tom, is them coming in. What came first, the chicken or the egg? A lot of these people get off the drugs and alcohol, and all of a sudden, over the course of time, it does take time, they turn out to not have any mental health diagnosis. Most of it was driven by alcohol or drugs. And I think one that came up recently that I've been seeing a lot is alcoholic-induced anxiety. Is that the proper terminology? Mm-hmm. Alcohol-induced anxiety?
Alcohol-induced mood disorder, anxiety disorder. Mm-hmm.
But generally speaking, every client reports anxiety, for instance. And once you work through the kinks, get them through detox, all that stuff, we're kind of in a spot. And I think where you were going with the whole Piers Morgan interview thing was he was talking about how we're overdiagnosing mental health, so to speak, if I understood it correctly.
I don't know that he really says it. It's overdiagnosing. The context of the clip is really, where is it coming from? He may mention in there, I'd have to rewatch it, but I don't know. I think it was more around like, where is it coming from?
Well, they discussed a few highlights. One of them was the overdiagnosis, the increased prevalence in this day and age versus, 20, 40, 60 years ago. They use actually the different wars as reference points, like World War One, World War II, Vietnam, and moving forward to present day and the generational differences.
I remember now. Mm-hmm. Yeah. And it was actually in the clip, it was almost you're coddled in a way when you have some sort of mental health issue, and I think a lot of that clip, the context was around depression and anxiety. Like, it's not so much that you're celebrated, but we have developed into a culture of, if you have depression and if you have anxiety, now you can play more of a victim role.
It's like a badge of honor, if you will. I see that a lot of the times. And, I don't want to sit here and sound like this stuff isn't relevant, but very oftentimes in conversations with clients, they'll come forward and they'll say, oh, well, I'm behaving that way because of my depression. And while there's some truth to that, I also, like what you're saying, Tom, a lot of time I think it's a cop-out. And what I tell our clients, before we do this workout stuff that we do, and I've talked about this on previous episodes, where at Rock, my reason for doing the workout, so to speak, more so than, getting physically better, is more for the mental health aspect, the endorphin release, etc. I end up saying to our clients, point blank, you might not be responsible for your mental health as far as having it. Maybe you're born with it, etc. Maybe it's genetic, whatever the case may be there. However, we are responsible for our recovery. And it's the same thing with the drugs and alcohol. I just translated it to the mental health side of it. If I have depression and I've been diagnosed with depression, you can either coddle me, or I could take the bull by the horns and say, you know what? Today I'm responsible for getting my feet out of bed, putting them on the floor, and getting them moving. And what does that look like? And that's a big part of the approach that I take with a lot of our clients, because I'm not going to sit there as somebody trying to help them and just watch them be miserable and pat them on the back. Yeah, well, I lift them up, of course, like say kind things, encourage them, absolutely. But at the same time, I want to be very direct and straightforward. The only one that can really do anything about this is you. And I think that we've kind of gotten away from that, trying to be too understanding, if you will. It's their mental health. Because I hear that a lot. I'll be straightforward. I hear that from a lot of therapists, not necessarily here at Rock, but they'll say, oh, they're acting out because of XYZ diagnosis. And while that may have some accuracy to it, at the same time, it's an excuse for them. And
doesn't make it okay.
And our clients have become used to that. Oh, you don't... No, that's my ADHD. That's why I'm interruptive in group, and that's why I talk out of turn and say inappropriate things. Okay, the first couple times. But once we start addressing it, like there's a saying that I was taught, I'll accept you for who you are, but I will not accept your behavior. and kind of drawing a line between the two. Do we want to be compassionate, understanding? Yes, but we also, as professionals, have to hold people accountable as well. And there's a fine line there.
Yeah. What do you see from a medical standpoint? Like if somebody comes in, and I guess my question for you, T, is how many people from your experience would you say are actually clinically depressed versus, have developed the mindset of it's just easier being depressed?
It's difficult to say. I mean, in this setting, in the addiction setting, it's different than the real world setting because we're treating patients that are actively using substances, which adds fuel to the fire, right? So
let's keep it in context of addicts then.
Okay.
Yeah.
It's really hard to say because I often see them early on when they come in and they're going through it. They're detoxing, they often come in high or drunk or whatever. So the first couple of days, everything's great. And then once those substances finally wear off, you just see this spiral go down. And, then you start to really understand where they're at and where they're coming from. But when you see them initially on day one and you ask them about their diagnoses, I would say more often than not, I can't necessarily give a percentage. They'll tell you, like Ben says, oh, I have depression, anxiety. Well, from my standpoint, from a physician standpoint, I say, well, what type of depression were you diagnosed with? And they are like, just depression. And I say, okay, well, is it, bipolar type 1, bipolar type 2? Is it major depressive disorder with psychotic features? Give me some more background data. And a lot of the trend that I see is a lot of the patients that go through different treatment centers because, as we know, the statistics, most people don't get it on their first try. They are often given these blanket diagnoses when they didn't necessarily meet criteria for them. So they were either diagnosed, during active addiction or going through withdrawal. And I think we've spoke about this before, that we're traditionally taught you can't give someone a true diagnosis of a mood disorder or an anxiety disorder until a patient has at least, 6 months to a year sobriety, because you have to rule out all other things, like complicating things that could present itself as such. And so I think Ben and I briefly spoke about this. I think there's over education that's, by social media, and then the internet, Google, we have access to everything at hand, patients, providers, etc. But the true DSM-5 criteria for generalized anxiety disorder or major depressive disorder have specific criteria and stipulations. And unless a patient has actually sat with a provider to go through those things and have experienced those symptoms on a consistent basis in multiple avenues of their life, the true diagnosis it's usually, very not hard to diagnose, but people don't often meet criteria when they go back and really look at it and what the criteria is. So it's used more as like slang, or like you said, I feel depressed. Well, what is your definition of depression? I need to know from you, what feelings are you feeling? How are you feeling? How is it affecting your life? Nature versus nurture. What happened in your childhood? That types of thing.
I want to say one of the quiet parts out loud because I think it's just we should kind of speak the truth. And I don't know, you would know more than me. It is my thought on this accurate, where I think also trying to meet criteria for insurance companies facilitates a lot of this as well. I don't think we've ever talked about this, but it popped in mind when you mentioned the DSM-5. The DSM-5 is the
Bible
Diagnostics and Statistics Manual.
Wow, look at Tom coming out of left field. I wouldn't have been able to throw that out there.
So you were saying the Bible. It's not the Bible. It's the Bible of mental health. Is that what you're?
Yeah. So
it's basically what you go to as a reference to be able to guide it has all the diagnostic criteria of
Yeah.
mental health disorders.
Right.
So I'm just trying to, connect the dots here, because one of the things that I see is we get sent medical records from like detoxes, for instance, and the clients have access to that. Like they hand them what's called their face sheet as they're leaving, and they glance at it and see what their diagnoses are. I'm just going to throw it out there that, for instance, at a detox level of care, in order to get paid by insurance companies, there has to be diagnosis codes. For instance, like what's one, depression, for instance, is F whatever. And there's literally a list. It's a box right at the top that lists them off. Mm-hmm. And generally speaking, a client will have anywhere from 3 to 10 diagnosis codes there. And I want to say that those are put there with good intention of these detoxes, because at the end of the day, treatment centers are supposed to, quote unquote, fight for their client to be covered by insurance. And I'm just going to say the quiet part out loud, that the worse a client looks on paper, the more likely an insurance company is to, A, give them longer treatment, which we all know that I think we're all in the same camp. The longer somebody can do treatment, the better. Mm-hmm. So really you're advocating for this client, and the detoxes are doing the same thing. And it's not just detoxes, but that's where they start. That's why I'm saying that. But it kind of just filters down, and all of a sudden the client has this piece of paper. He's like, look at my diagnoses. Yeah, when in reality, as we've talked about in the past, they're getting that in a week of detox. There's no way to truly know, but if that's being reported, then they are going to get the care they need. So I just hate the fact that insurance companies dictate treatment, treatment plans, treatment length of stay, all that stuff. So I'll just call it what it is with them, with the treatment centers. It comes down to money. And as much as we want our charts to be accurate, in many cases, they're not very accurate, if that makes sense.
Yeah, I think Brad would be a good person to consult. And Brad is our guy he's our utilization review guy. So he's the one that talks to a lot of the insurance companies, and, he references the charts and stuff like that when he's talking to a case manager around a specific case. But I will say this, and I agree with everything you said, but insurance companies, a lot of times they put a lot less emphasis on mental health than they do actual physical, like medical criteria, because there's some insurance companies out there, and it all depends on levels of care, what level of care somebody is looking to go into. But for us, we're PHP and IOP. A lot of times the insurance companies, they don't care about if somebody, they care if you have depression, they care if you have anxiety, but that, generally speaking, isn't going to get you more days. Now, it will help in terms of like a little bit, but a lot of it, they're looking at the bio, what do they call it? The
biomedical
conditions? The biomedical conditions.
Detox level of care is technically medically managed. So they do look at biomedical conditions and their risk. The more the patient has going on, the more they feel that it's necessary for the patient to maintain that level of care. Once you get past detox, they say residential level of care, PHP, IOP, OP are more clinically managed level of cares. And that's when they start really looking into the clinical presentation. So their symptoms of what they're struggling with, depression, anxiety, cravings, how is it affecting their social life, are they homeless, their financial strain, the legal issues they're facing. So they look into all of those other things that also come together. Yeah,
and I think that like as they move down in levels of care, IOP meaning intensive outpatient and outpatient, they have a lot less criteria that you need to meet in order to get approved those days. But they are still looking for, because I've had these conversations with Brad, and like high blood pressure is something that I hate to say is from an insurance or a coverage standpoint, it's a good diagnosis to have, I guess, in terms of getting treatment, because a lot of times your high blood pressure is a result of your alcoholic drinking, which is a result of your alcoholism. So if you have continual high blood pressure and like, hey, we want this person to stay in this level of care, we're still treating their blood pressure, we're trying to get their blood pressure under control, through medical interventions, seeing the doctor once a week or whatever. Insurance companies are like, okay, yes, yeah, because that's like actual physical ramification of their alcoholism. I hate to say it, but like I've talked to, and I keep referencing Brad. None of you listeners know who he is, but we work very closely with him, and he talks to the insurance companies every single day. I'm like, well, Brad, this person has extreme amounts of PTSD, which is post-traumatic stress disorder. Maybe this girl was, sexually abused for years and years and years, or whatever the case is. They have high levels of PTSD, and it doesn't hold. It doesn't hold with a lot of the insurance companies anymore. Or I say anymore, I don't know if it ever has. They are looking more, because I think from an insurance company's perspective, and we've kind of veered off a little bit, but not really. From an insurance company's perspective, they're looking at, if you have PTSD, well, that can be managed. Just go get a therapist. Go get an individual therapist and, go see them once a week. Why do you have to do all the groups? I mean, you're a substance abuse facility. They've been clean and sober now 90 days. They can go off and get an individual therapist and do EMDR. Even though we do all that stuff here in-house in the group, we know, and this goes back to your point, Ben, hating the fact that insurance companies try and dictate clinical treatment, because we know what works best. They're in a controlled environment, relatively controlled environment, safe, secure, therapists basically at their disposal, stuff like that. It works, but from an insurance company, they're like, well, we don't necessarily care. So anyways.
I think too, to kind of change direction back to where Dr. T was going, you mentioned like there's mental health is on the rise, so to speak. And I think culturally we've changed. You were talking about the wars and the overexposure. Mm-hmm. I mean, just to state the obvious, today's generation is exposed to social media, and there's almost I feel like a type of pride with mental health diagnoses. Like, I don't know if that makes sense really, but it's like, hey, I'm part of this group. Yeah. And I was just looking, I was talking with our director of operations, Nick, prior to this episode, and I look at even the differences in treatment now. When I was in treatment 13 years ago, there was no Uber. There was no Uber Eats, DoorDash, all that stuff. Like, and today we have clients that are like, oh, I can't go get a job because I don't have money for Uber. And I'm just thinking to myself, like, dude, I used to pound the pavement. Like, and this is the area I got sober in, so you can do it too. And it's instead of like they render themselves helpless and everyone wants to kind of go in like you were talking about earlier and coddle them through this situation. When in reality, like a lot of times it's my opinion and based off of my experience, like you just need some hard knocks. I'll call it what it is. And again, I don't want to disregard true mental health diagnoses when people legitimately have it. But I think just this idea that culturally we have to save everybody who says they're depressed, when in reality, sometimes we just need to sit them down and say, here's what you need to do. You're responsible for it. Because how much of it's environmental? There's a difference between biomedical and environmental situations. Nature, I'm super depressed.
Nature. Yeah.
Well, you just lost your job from drinking. Your wife just divorced you. Is it real depression or is it situational?
Yeah. To piggyback off that, I think, like you said, is it situational? On the Piers Morgan interview, they talked about, instead of, they kind of talked about the overdiagnosis in this day and age, but they talked about the why. Why do people feel they are depressed or anxious? Going back to that. And instead of saying, here your treatment is a pill, here your treatment is therapy, which it is. However, if you're properly diagnosed, right? So going back to the why, and I think the social media and all that plays into it, right? Like we know in our brain, true depression, true anxiety, the pathophysiology is derangement in your norepinephrine, your serotonin, your dopamine, right? That's just basic knowledge. And if you have a true underlying derangement of your brain's ability to regulate those things, is what leads to symptoms of depression and anxiety. Now, when we watch things on Instagram or YouTube, these things flood that make us happy. That's what AI is. That's why they target us with different reels and Instagram ads, etc. And you're showing young children whose frontal cortex is not even, slightly developed, 7, 8, 9, 10 years old. You're already exposing them and overstimulating their brain to have these surges of dopamine, serotonin, norepinephrine. And these are things that we weren't exposed to when we were that age, right? So, I think that's one aspect of it. But the other aspect, and adults the same nowadays, we all have social media. We're all, fall into that realm. But also when we talk with patients about what is underlying as well, is it, like you said, their environment? What was their childhood like? What was their upbringing? Did they, were they homeless? Did they live in homeless shelters? Did they suffer trauma? Did they have a really good family and had the right path? So we look into the nurture aspect of it, but then we also ask them family history. Is your mom or your dad suffer depression? Is mental health run in your family? Has anyone committed suicide? So the why, is nature and nurture. It's a combination of both. But when you are diagnosing someone, those things are really important. Like if you go to a provider and you're struggling and they don't sit down with you for 10, 15, 20 minutes to ask you these questions and understand where you're coming from, then maybe you should seek a different provider, because maybe they are just looking to get you in and out. Here's a pill, here's a referral to a therapist, good luck. Instead of saying, hey, what's going on in your life right now? Maybe I'm drinking a handle of vodka a day and I'm experiencing sweats and all these things. But if you can talk someone through that, then you can help them find the why.
Yeah. Well, a lot of and I'll reference myself, when I first got prescribed anti-anxiety meds, I didn't really know what was going on with me. I just knew that I felt whacked out of my mind, and now looking back on it, it was alcohol withdrawal. A lot of it was, and they framed it as anxiety, and that's when I got my first script of Ativan, and I fell in love with it. And it was something that had become a crutch for me, and ultimately ended up, making me spiral more out of control. I'm drinking and taking Ativan, and then, taking Xanax, and then, the story goes from there. But it's good.
But with medications, to advocate for yourself as a patient, but as a provider too, the most important things to talk about is, one, how do you feel about medications? Have you read about them? Have you researched them? What are your thoughts and feelings and objectives for yourself is what I ask people. But if you do decide to go down that road, and if it is necessary, what are the risks? What are the benefits? And what are your alternatives are the most important things to talk about, when you write a prescription for someone, so they understand. And I tell people all the time, hey, this is what we're looking at. I'm just going to give you a couple names of things. We're going to talk about them. And then I also want you, when you leave here, to go on your own and do research and come up with your own set of questions from your own objective point of view, so we can have a conversation on a follow-up visit in a week or two about it. and then make the best decision like as a team. So if you have a provider like that's not like that and not vested, then maybe.
Do you hear that? That's what makes a good provider. I'll never forget this. It's kind of funny. I would and I was actively using, but I was seeing a psychiatrist at one point. She was from Haiti, and I only bring up she was from Haiti because of her accent. And so I would walk into the office. I'd sit down with her for like 3 minutes. She's like, "Oh, how you feeling?" I'm like, "Oh, I'm just super depressed." She's like, "Oh, I give you this. This is the best. This is the best medication." And every time I would go in, like a month later, I'd be like, "Oh, I'm depressed." She's like, "Oh, we tried this. This is the best." Everything was the best.
What was it though?
I mean, Elavil, Wellbutrin, Seroquel, you name it. Like, I would go in there with these and just say a symptom, and she would just like throw a medication, and this is the best.
Right. But unfortunately, the nature of today's society and medical is that, most providers are, in a rush to get through patients, and they're just like, here you go. I'll see you in a week or two. You should go see a therapist. But that's the unfortunate.
So we know
reality.
that about your approach, that you get the clients to interact with their own plan, really, is a lot of what I hear. I mean, you send out the notes afterwards, and we see like you'll put what you talk to them about, and then you're going to reconvene the following week after they put some thought into it. And that's a great practice. You're not just taking, "Oh, they told me they're feeling this way. Here we go."
When my dad had this stroke, it was really a big learning experience for me. Just kind of how to navigate it and stuff like that. And I never knew how many medications he was on. And then, fast forward to today, he's probably on, I would say 7 or 8 different medications. Nothing, I mean, which I don't think is that much. Hell, I've seen clients come in here that have double that. And I'm like, holy cow. But anyways, where I'm going with this, every time I pull up and pick up his meds, they're always like, "Do you have any questions for the pharmacist?" And I'm like, no. But even if I wouldn't even know what to ask. And I think that's the reason I bring that up is because I agree with you 100% that like people should be invested in their treatment. But the reality of it is if you have 10 patients walk into your door, out of those 10, how many, and maybe I should say 100, out of 100 patients, how many of them do you think will actually read the pamphlet that comes with the medications or go on and do the research? Because, and again, this falls back on like societal standards, and the standards that we have set is doctors know. And the doctor told me, and the doctor is the one that is supposed to know what's best for me, so on and so forth. So it's like a double-edged sword, because I understand from a patient perspective, like, I shouldn't have to ask because you're my doctor. But from a doctor's perspective, they're like, well, I have 30 more of you that I need to see today, and I'm not going to have time to answer all these questions. So it's a really tough spot to be in. And, mental health even more, because it's not like, diabetes, there's a test. You can know within 10 minutes, get an A1C level and, fasting blood sugars, yada, yada, yada. Okay, you're probably diabetic, or you're pre-diabetic. Blood pressure, slap a cuff on an arm. You got high blood pressure, EKGs, all this stuff like there's tests for. Mental health is client-led. You can only diagnose based off of what the client is telling you generally, unless you have access, like if, they're under 18, you have access to their parents or their guardians and they can speak into their treatment. So it's a really, really, really tough place to be from a provider and a professional perspective and the client, because they're like, well, a lot of times they may not know, they may not know what is really going on with them. And that was the case for me. I didn't know. I just knew that I felt really, really weird. My mind was racing a lot. I was getting like sweats, clammy, stuff like that. And I don't know.
And somewhat related to that, we were talking about this before we hit record, where we often have clients that, you know, you ask them their input. Here, they've been smoking meth for 10 years, and now all of a sudden they don't want to take an antidepressant to either like get them going again if their brain needs it as a jump start, or something that they may need permanently. Maybe they've done permanent damage and they need, I don't know, some kind of antidepressant to replace that. But with that being said, it's like funny, like, hey, you know, last week I'm shooting heroin with the toilet water, and now I'm like vegan and I can't take any medications. Yeah, we were talking about that.
I often, and that's kind of what I face. I do face a lot of resistance to, and I'm not one to push medications on people. I'm not that person. I'm not that provider. But I do have, there are barriers, I would say, to a lot of patients in the treatment setting. You know, I think there's a lot of distrust for physicians in the treatment population, rightfully so, because a lot of the blame comes back to prescribing habits and practices, and I don't disagree with some of that. But, you know, to earn that, it's like my goal is to earn that trust slowly and break that barrier and educate because of that resistance, but not only from patients' side, you also get it from parents and loved ones. You know, I'll often get calls, can you please call so-and-so's mom because they're really concerned that you started the Lexapro medication for them. You know, why did you start it? How long is she going to have to take it for? Is this a short-term thing? Is it a long-term thing? I get a lot of questions like that. And I just try, obviously each patient and scenario is different, but I just try to be as honest as possible with that time.
Talking about resistance, because we see this often, and I was wondering how, like, what approach you take with it. A lot of times we'll get clients who have been on something in the past, and generally in my experience, they haven't been on it long enough, but they bring up like the side effects, like, oh, I don't like the way this medication makes me feel. And generally I kind of see that, you know, it's usually the first couple weeks where you feel the side effects up front. Like I remember for me starting Elavil, like the cotton mouth I got was so bad. And I was told about it ahead of time, you know, for like 2 weeks, but then that eventually like my body adjusted and it went away. But like, how do you navigate clients that discuss previous experiences and they weren't what they were? Maybe they were on drugs when they were taking it.
That's what I always try to ask them. First things first, tell me what you've tried in the past. Were you actively using when you were supposed to be taking the medication? That's most important, because oftentimes they're like, oh, yeah, I was actually using at the same time. But also, like, did you take the medication every single day as prescribed, you know, like a regimen? Did you miss a few doses here and there, or did you only take it once or twice a week? Just trying to tease out what exactly was going on in that moment in time. And then I'll ask them their exact, like if they were either way, whether or not there was co-founding factors, but what were those side effects? Some of them, it ranges from the biggest one I get, to be honest, is sexual side effects.
I had a feeling you were going to say that.
Yes.
I hear that.
So that's a big discussion we have. And that always goes back to like risk benefit ratio. You know, is the risk of the side effect outweigh the benefit of the medicine and where you're at, you know, with your mental health. But there are newer medications and antidepressants that are less likely to cause those side effects now. So as time progresses, newer medications are coming out with less side effects. So those are always options too. So I always try to put the pros and cons for everything out there and just make a decision based on, you know, their history and comfort level.
I think too, if we discuss like diagnoses that are accurate, for instance, with like schizoaffective, etc., I hear a lot of the times a client they'll be taking their medication and be good socially, everything looks like it's going great from the outside, and then all of a sudden they stop and they say it's because they'd rather feel something than feel nothing, you know. And
I get both ends of that.
Yeah.
So I get that end of it, that sometimes the medications make them feel numb. So they're like, I feel like I'm here, I'm existing, I'm going to groups, I'm doing my meetings, but I can't even cry. Like if you ask me about something sad that would usually make me cry, I can't cry and I can't like express joy. So, that I get, but I also get, hey, I've been taking this medication, Lexapro for 3 months. I feel great. Everything's perfect. I'm getting back into a routine. I'm sober. I'm doing meetings and steps, and they abruptly stop, and then they unravel within like a week or two on their own, and then we'll come back and say, so I made a decision, a couple weeks ago to just stop my medication because I was feeling normal again. What's going on? And so that conversation ensues as maybe the medication was actually helping you at that moment in time. But also these medications, some of them have to be tapered off slowly over a couple weeks. So abruptly stopping it is not always the best decision either. And that's why we should always have a conversation about it.
I'm trying to think of questions like parents ask. Now I feel like I'm kind of on a roll where one of the concerns I hear from parents a lot too is like, oh, this detox put my son on 8 medications. Is there a point or like where I almost like their interpretation of it, and I kind of see it the same way I think too, is like they start a medication, then they get a side effect from that, add another medication to counteract that, and it just snowballs, and all of a sudden, like I've seen clients here show up with like 3 1-gallon Ziploc bags of medications. And the first thing that happens is I hear it from the tech, because the tech's like, oh my God, I have to count every single one of these.
Yeah.
And they've literally counted 3,000 pills. Maybe I'm exaggerating a little there, but
there's multiple instances with that too. So one case scenario could be like how you're saying, a lot of the, I would say, and we've talked about this before, 90% of patients' complaints that come to like our level of care, PHP, IOP, OP, sleep is still a big issue. So, we always try to minimize the medication for sleep. But when they're in that detox, because I also do detox and residential level of care, they're like, if I don't get sleep in the night, like I haven't slept for 3 nights. If I don't get sleep tonight, I'm just going to go out and use because that will make me sleep and I can't live my life like this. So that's when you have to have like a sit down with a patient and talk about, okay, what's really going on? So I think oftentimes that's when the medications start piling up in like the detox residential level of care, because you try different medications. One works or one doesn't, and then they change them around. But those scripts are in their name. So they'll still leave the detox with all those scripts, even though they're supposed to just do a med rec before they leave. Like that's one way. But the other way is some of these patients will be in multiple detoxes, get multiple scripts, and then they just carry their bags with them to every treatment center and come in with like 3 bags of things.
Yeah.
It's funny. I've noticed, and I think I've only been paying attention maybe lately. I'm pretty sure it's probably always been happening. But one of the questions on the pre-screen is, and they're generally sitting with a case manager if they're in detox, and you ask them, like, what are your medications and dosages? And in a way, I feel like, because we get the medical records anyway, so I'm going to end up seeing, but in a way, I almost feel like that question is to see if the client is with it enough to know what's going on. And very oftentimes, the clients, like, they can name maybe, like, a couple of the medications, no idea what the dosages are, they're just sitting there just taking whatever, and not good, bad, nor indifferent. It's just an observation I've had.
Yeah.
Where many of them are like, I think I'm taking this, but I don't know what it is. I just walk up to the little door and they hand it to me and I take it. And I mean, and oftentimes they say, like, when I go over to your level of care, I don't know what's coming within me and what's not, So to your point, I could see how it changes a lot and they kind of can't keep up.
Yeah, but then that's why when we meet with them here, I go through, this was what your discharge medication list was. Like, do you know what you're taking or why you're taking it? And we just go through each one by one and say, is this of benefit to you? Do you understand the risks, with it? Mm-hmm. is this something you want to continue on with? And that's kind of how we, they may have come in with 10 meds and we can get them down to like 3, and then eventually.
And I've noticed, like, I'll just throw this out there. Kudos to you. Like, I've noticed you spend a pretty good amount of time with each client. Like, there's been nights where the groups have ended. It's a 3-hour group at night and it's ended, and you're still seeing patients and the van has to wait, which I don't think that's a bad thing because you're taking the time to do it. But yeah, it's not quick with you, so to speak. Some of them, like, there's not much going on. They've been here for a while, in and out, just checking in. But I've noticed, like, there's been clients in there that'll sit in there for a half hour with you.
Sometimes it takes, more time than
or they just like sitting in there with you. And they're like, I don't need to be in groups. So
I do get that.
I'm not going to lie. They tell us about it.
And I'm like, all right, I need you to go back to group now.
Yeah, it's either I sit in here with you or I go back into group.
They'll be honest about it. I'm like, hey, I appreciate the honesty, but at this moment in time, you need to go back to group.
Yeah. Well, that was fun.
Yeah.
Good. We cover everything we needed to cover?
I think so.
I think so.
All right.
Yeah.
Well, that is it for this episode of Real Recovery Talk. Thank you for tuning in. In the end, if you have any comments, questions, or concerns, you could always reach us. info@realrecoverytalk.com. Again, it's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message. That is it. We'll see y'all later.